Dr. Ali Kuram, and I'm the Secretary of the British Society for Oral and Maxillofacial Pathology. We have now been running the Case of the Month series since April 2018, and thought it would be a good idea, in addition to the case being on the website, to do a brief video to go along with it, in which we can explain some of the features, the clinical history, as well as some of the learning points. So I hope you find this useful. So we will be discussing the case of the month for July 2021. So this was a patient who presented with an alveolar ridge swelling in the lower left central incisor region. So this was basically a swelling involving the gums quite centrally. And when clinically it was examined, there was quite a well-defined swelling and a lump involving the gums in that area. The radiology, which included both a dental radiograph as well as a CT scan, didn't really show any obvious intraosseous lesions. If you can see here, this is a periapical dental radiograph. You can see the teeth, central incisors here, lateral incisors here. This is the mandible bone. The space that you're seeing here is the periodontal ligament space. And you can see a slight shadow in this area. So the outline of this shadow, which is superimposed on this radiograph, but there's no actual intraosseous component of this lesion. So the provisional diagnosis in this case was a soft tissue lesion, and it was thought that this was related to trauma, so something like a fibrous hyperplasia or a polyp. So the lump was excised and it was sent for histopathological examination. I will be showing you some representative images from those slides, but you can actually access the whole slide image by visiting our website. And if you go to the website and the case of the month page, all you will need to do is click on the whole slide image link, and that will open a new page on which you can select the guest login option to view that image. Here is what that will show you. So when the specimen was received, it was trisected into 3 fragments, and even at low power you can see that it is quite obvious this is a cystic lesion. There's a central lumen present there. It appears to be lined by what we think is epithelium at this power, and towards the periphery there is quite a thick fibrous tissue wall. When we have a closer look, the cyst lumen appears to be filled with this pink material, and there's an obvious epithelial lining surrounding this, and you can see there's a cyst wall which has got focal aggregates of inflammatory cells within it. If we zoom in even more, we can see that the lumen actually contains quite a lot of desquamated keratin. So these are just fragments of keratin, and the epithelial lining shows quite a prominent parakeratin surface. You can see that nuclei are still retained in the surface layer. And this epithelial lining was also irregular and appears to have a corrugated surface. And by corrugated, I mean this sort of irregular and undulating surface. The lining appears to be about 5 to 8 cells thick, and another quite prominent feature was this basal cell palisading or reversal of polarity, which is quite a common feature for odontogenic epithelium. Another picture showing similar sort of feature, you can see the corrugated surface, prominent parakeratin, and basal cell palisading with minimal inflammation in the wall. If we zoom out again a little bit, you can see that largely the cyst wall is uninflamed, but there are focal areas where you can see some aggregates or mixed chronic inflammatory cells, and these predominantly comprised lymphocytes and plasma cells. You could also perhaps notice and some occasional fragments of vital bone which were present towards the periphery. So all of these features point towards a peripheral odontogenic keratocyst or an extraosseous or mucosal keratocyst. So what things can we learn from this case? I mean, as most of you know, odontogenic keratocysts comprise approximately 10 to 20% of all odontogenic cysts, and these are derived from the dental laminar remnants that are left behind in the jaws. The histological appearance of OKCs is quite characteristic. As we looked earlier, you've got this parakeratinized surface, a corrugated appearance of the surface, and the epithelial lining being approximately 5 to 8 cells thick, with quite prominent basal cell palisading and reversal of polarity. and almost all of them are intraosseous. They tend to be largely asymptomatic because keratocysts grow by expansion into the marrow spaces within the bone, and quite a few times these are actually referred to the hospitals as an incidental finding, which actually looks quite large on the radiographs, and the patient doesn't have any symptoms. The peripheral variant that we saw in this case is quite rare, but there have been approximately 40 reported cases in the literature. Most of these tend to involve the gingival tissues, which makes sense as some of the odontogenic epithelial remnants are left behind in the gingivae as well. However, occasional cases have been reported which involve the buccal sulcus and the retromolar area, so that's towards the posterior aspect of the gums behind the last standing molar tooth in the mandible and the maxilla. What we think is that this is not related to Gall and Cole syndrome, and the management is quite similar. So you would like to enucleate this cyst, but nothing more than that should be required. The recurrence rate of these is also supposedly less than the intraosseous keratocyst. So simple enucleation should be sufficient, and these cysts shouldn't come back once they're removed. And we do think that these arise from those remnants which are left behind in the gingival soft tissues. However, we're not exactly sure about the precise etiology. The important thing to consider is to, of course, do some radiographs and make sure that there's no intraosseous component, but also rule out other lesions which can have a similar appearance. So cysts such as an epidermal cyst or a dermoid cyst, in which you can have a keratinized epithelial lining, but you wouldn't have the parakeratin that you see in this case. You would not see the basal cell palisading that is characteristic of an odontogenic keratocyst. And also with these other cysts, you may see some skin appendages in the cyst wall as well. I hope you found this case useful and interesting, and thank you for watching. If you want to learn more or join the society, please visit our website bsomp.org.uk. We're also on most of the social media channels, and you can follow us there to learn about these cases and other relevant events. And also, if you want to keep an eye out for more cases in the future, please subscribe to this channel. On our website, we have access to all the cases going back to April 2018, so please do visit, and I hope you enjoyed the session. Thank you.